So, okay, put something on that. Okay, what I did is I sent Ron all the questions from the earlier clinical panel that were DO15Q specific. And so he has them kind of at his ready. So he's going to just address some of those first, but we will, if you guys have questions for him after that, we're opening it up, okay?
Okay, great. Can you hear me okay? I want to make sure the volume's working.
We can hear you.
Okay, great. Yeah, so as you can see, since this morning, darkness has fallen in New England, and I don't have great lighting in this room, but hopefully you can see me well enough. But as long as you can hear me, it's more important. Yeah, so there were some really great questions from this morning that that Vanessa had sent over. A lot of them kind of go together. We touched on it a little bit this morning, but a lot of questions about age, age of seizures, age when they might stop, ages to come off medicine. Just in general, the epilepsy can be so diverse in different kids. There's a few different ages where different seizures might pop up. The first thing is infantile spasms. Those occur within the first year, usually somewhere between 4 to 8 months is kind of the typical range, but anywhere in that first year. They kind of consist of head and arms kind of flexing forward. They often come in clusters. They almost look like hiccups, but they're just very rhythmic. And then, once the cluster is done, the babies are often kind of tired, or they can be a little bit cranky. If those don't occur in the first year, that's always a good thing. And then often we don't see seizures happen very often the next couple of years. They may start in kind of the early school years, kind of 3, 4, 5, either the kind of easier to treat focal seizures, or sometimes some more difficult to treat, like that was one of the Lennox-Gastaut type seizures. But the more difficult seizures often, they can start that early, but in DO15, it's a little bit unusual for Lennox-Gastaut. It often starts more like 7, 8, 9, 10, as opposed to 3, 4, 5, which is a little bit unusual for those types of seizures, but they tend to start a little bit later. So that's one of the things to think about. If you just kind of look up Lennox-Gastaut, you read about it, it'll say like, the average age is around, 2 to 3, 2 to 6 is kind of common. But for DO15 specifically, it's typically a little bit later. So it can kind of come later. One of the big things to remember is that 40 to 50% of people just won't have seizures, which is great. And for people that are doing well developmentally and haven't had any seizures as they go towards puberty, sometimes they'll start with puberty. Either for girls when their periods start, or for boys when they have the big growth spurt, you might start to see some seizures. They're often the focal kind, so more typically kind of long staring spells. And not just to kind of where you call it once or twice, they turn around, but 30, 40 seconds, a minute, like longer spells. There might be some eyes or the head to one side. There might be some kind of strange posturing of an arm. So those can kind of sometimes come up with puberty. On the silver lining kind of it is those are usually much easier to get under control than the ones that younger kids get. But once you get to puberty and you get, you have your, you kind of get to that age, like at 12, 13, where everything really kind of starts happening. And the more years out, the less likely the seizures are to come. It's never zero, but once you start getting to 16, 17, 18, 19, the risk is much lower. And if you get into your 20s, again, it's not zero, but it's very low once you get to that point. What we don't know is kind of what happens when people get to be 40. That's kind of a new enough diagnosis and a new enough gene where we just don't have a lot of people that age. We've seen, at least in our clinic, a couple of people in their 30s, but most are kids. And now that we've been seeing people for 10, 11 years, we have more people in their 20s. We haven't seen any kind of aging changes in the 20s, but as people start to get older, we'll see if there's anything later. There's nothing that tells us that something is going to get worse later in life. So it's not that we're expecting that, but we just don't know specifically, that things stay good or get better as people get older. We're just not quite sure yet. But yeah, so as far as getting seizures, that it's never zero at whatever age, but if you haven't had them yet and you get into the teen years, every year, it's the likelihood just goes down. As far as coming off meds, that's never an easy decision. kind of the typical guideline that we use is there are a bunch of studies done back in the 90s, like with thousands and thousands of kids, and the kind of the basic consensus was that if you're 2 years seizure free or EEG doesn't have any spikes on it, then you have a 90% chance of coming off of meds. But those were done in kids that didn't have genetic syndromes, developmental disabilities. You know, you definitely could be seizure free coming off the medicines, but it's not that 90% chance. It's probably more like 50-50. You just don't know. So it's kind of a pros and cons thing. Like it's gonna be a little bit different for everybody. Someone whose seizures were really hard to get under control, and then they got under control, and they're not having any side effects from that medicine, then that's someone that we'd probably want to leave on. It took a while to get that kind of control. There's really not been an issue with the medicine, so that's someone I might want to just keep, maybe not indefinitely, but at least for a while. Whereas someone who never really had seizures that were that bad, and then they are doing okay on the medicine, but maybe it's got some side effects. That's someone that I would be much more likely to want to come off and say, if the odds of worsening seizures aren't that high, and there's some side effects we can get rid of, then it's worth. So it's really kind of weighing the pros and the cons, like the history of like what happened in getting there as far as making the decision. So there's, the good news is that there's really not a right answer. The bad news is there's really not a right answer. It's going to be a very individual decision, but some people do come off meds and stay off. Others come off and have to go back. So it's just that risk versus the reward of coming off really depends on what medicine you're on and how tough it was to get there. There's a couple questions about diet. So diet therapy can be really effective in treating seizures, and we use it a fair amount in the Angelman community. We use it a lot. It was just one of those things where we did a trial, and kind of word got out that it was successful, and people just started wanting to do it. It hasn't quite taken off in the DUP15 community, but diet therapy really is potentially effective for any kind of seizures for any reason. We had like one of our best success stories was a boy that we put on the ketogenic diet and did great. For dietary therapy, the big thing is just that it's not easy to do. So basically, the younger the better. If you're starting it in a 18-month-old, 2-year-old, before kids really understand what cupcakes are, that kind of thing, it's a lot easier to have them grow up eating sugar-free foods, and then if they do it long enough, they get to the point where they don't know what sweets are like, and they don't reach for them. There can be some constipation, some reflux that we can help with different diet changes and medicines. But the groups that it's best for are the younger kids, and then the group that it's really successful or that it's easiest to do is kids with feeding tubes. So if it's someone that has a G tube for whatever reason, it's just a matter of changing the formula. So there's not going to be any behavioral issues. There's not going to be a lot of fighting you, a lot of sometimes just not getting enough calories or fluids because it's just not food they want to eat. When it's just going through a tube, it's just as easy as changing the formula. As far as giving it, we have to monitor labs and everything to make sure everything's okay. But for kids that are fed that way, that's a really good option. The ketogenic diet's really restrictive. It's less than 10 grams of carbs per day. The low glycemic diet is the one that we typically use for kids that don't have tubes, and that allows for 40 to 60 grams, so it's a lot easier. And it's you're not always weighing foods like you do with the ketogenic diet. You just kind of, based on portion sizes, you're able to kind of estimate the amount of carbs people are getting. And there was one question about diet for stimming. I don't know if anyone specifically looked at that, but one thing that we do see with low carbohydrate, high fat, high protein diets is that you don't get the sugar rush kind of thing, and then the following crash, like when the insulin kind of kicks in. Glucose levels, insulin levels stay nice and stable, so you don't get those ups and downs. So we tend to see kids on diet therapy just be more focused and be more alert, and so that could lead to less stimming if stimming's an issue, and medicines haven't really helped it. It's possible. But it's one of those things, again, it's pros and cons. If it's causing other behavioral issues to withhold certain foods, then even if it does help the stimulate a little bit, if it's causing outbursts and kind of meltdowns, then it's kind of the downside outweighs the benefit. Let's see. Yeah, I'm trying to go through these quick so we can have time for questions, but there's just a lot
we
of really
did
good
get
questions.
a couple new ones in the chat. So Allison Kelnicki, I actually wanted to this. You said you talked about this 2 years ago, and I was curious as to what the answer would be. So Allison's son is 19 years old, and he's went over 10 years without any major seizures. Is this a time to reduce meds?
It's a good question. So I would kind of go back to what I just mentioned. If the seizures weren't that bad to start with, getting to age 10, then it might be worth it. The other thing is the side effects. If it's a medicine. The other thing too is depending on what medicine you're on. Like for some kids, if they're on like a Lamictal or a Topamax or some of those kind of medicines, they can also act as mood stabilizers. So we've had kids that have done great, and we said, you know what, you're doing great, you're seizure free, let's try to come off, and they've come off, and it wasn't so much they didn't have seizures, but their mood went downhill, and then we had to put the medicine back on for mood stabilization. So if the medicine could potentially be doing two things, then it's easy. Just if it's helping with mood, you just keep it on for mood, and then you have that benefit of the seizure protection. But if it's a medicine that's really only for seizures and it's not really helping with much else, and it's a medicine, especially it's like a Depakote or something where you're needing to draw blood fairly frequently, you have to supplement with something like carnitine. Then it may be worth trying to come off. And then, like I said, there's probably a 50-50 chance that you stay seizure free. If the seizures came back, you could always try a different medicine that was, potentially has less side effects. So again, it's, if, after 9 years, I think there's a really good chance that you don't have any seizures. But, we've taken people up, with DUP15, but also with other similar type syndromes or even idiopathic autism, where they've had seizures for years. They had one, and then we put them back. But then we'd have kids that would have one. We said, let's see how it goes, and then they'd go a year or two without another one. So it's really at that point, when you have that good decision to make, can we come off? It's about quality of life. The potential risk to quality of life if the seizures return and then they're harder to get under control, versus the quality of life off the medicine. If the seizure risk is low and there's definitely going to be a benefit to being off the medicine, it's probably worth trying it. If the seizure risk, if it was really hard to get control to that point, and there's really not much in the way of side effects from the medicine, then it's safer to leave it. But those are the two things I think about. How hard was it to get controlled, and what are the pluses and minuses of the medicine? Is it helping with something else that's easier to keep it on? And is it either causing side effects or leading to blood draws and supplementation and other stuff that you just want to get rid of?
Okay. Have you seen AEDs increase GERD issues?
Yes. Certain ones, certain ones that I enjoy, like clobazam, the benzos, those can worsen GERD. If it's one of those things where if you start a medicine like clobazam, and the seizures are much better, but it's causing some reflux, it's just better to treat the reflux than try to find a new medicine if the seizures have been hard to control. But yeah, there's probably a couple others, but the kind of benzo type meds are the ones that can really kind of slow down the GI system. Depakote can have some GI side effects too. Topamax can decrease appetite, Banzel can decrease appetite. So there's some medicines that have other GI side effects. Epidiolex, the cannabinoid medicine, can give you diarrhea. So sometimes if kids are constipated, that's kind of a nice 2-for-1. You can get a little bit of like free constipation treatment with your seizure control. Yeah, one of those things where, like I was saying this morning, where the side effects actually help. So some kids with constipation, we put them on that medicine, and they say, "Yeah, we're off the Miralax now. That's great." So you can use the side effects to your advantage.
Can that be a secondary indication for Epidiolex? It cures the GI issues.
Yeah.
So is there any more questions in the room? I have one more on the chat, but I know we want to wrap up because this is between us and dinner. What?
Got the hangry crowd.
No, it's okay. And then the last question on here, Ron, is the life expectancy of DUP15Q, but I'm going to let you ask hers first.
Okay. The myoclonic spasms you were talking about earlier that were not showing up on EEGs that I think you spoke of earlier. Could those look like a held in sneeze? I know that's like a really odd description of a type of behavior, but that's the best really description. I can tell you what she's doing.
Yeah, no, it's very descriptive. Yeah, no, it could, yeah. Kind of like a twitch. Yeah, like you need to sneeze and you don't, so you kind of do that. How old is she?
She's 9, and they do kind of come in clusters. And we caught it on an EEG and it didn't look like a seizure, which was at the time a good thing. But I'm just kind of curious if we should be treating this now or kind of just knowing it's there and knowing what it is and ignoring it.
It's for those, I was going to say just to, if everything else is going okay and there's nothing else seizure rates very unlikely to be spasms. If you've caught them on EEG and they weren't, then you can pretty comfortably rule out that being a spasm. So yeah, if she's had them on EEG and you're not seeing much, that probably is the non-epileptic myoclonus. And then the decision to treat is really based on the quality of life. If it doesn't really bother her, it's just like you don't enjoy looking at it, but it doesn't seem to bother her, it's okay just to let it go. If it's either like causing her to maybe lose balance, in a worst case scenario, fall, or trouble with eating, or if she just looks startled when it happens and it seems like it's kind of upsetting, that's when we would probably want to treat it just to make life easier.
What would the treatment be?
It would be even though it's not seizure, any kind of myoclonus will respond to medicines that treat myoclonic seizures. So something like clobazam or Keppra or something in one of those families can really kind of quiet that down. The other thing, sometimes we'll see more myoclonus during the day if sleep isn't good. So if you're seeing that and she's sleeping poorly, it could be more of just an indication that sleep isn't great, and sometimes fixing the sleep really quiets those down in the daytime. So
and I said I'm gonna also send her the myoclonus talk that you've given before. We have quite a few that we have that might be really beneficial for you. Last question where we're gonna wrap up on is life expectancy and DUP15Q.
Oh, an easy one. So
totally.
we don't really know, and that's a good thing and a bad thing. There is that increased rate of SUDEP. So people with tough to control seizures. There's that. I know that's been talked about before. There is that increased risk. It's still less than 1% per year. So it's a small risk, but when the risk of whatever it is that bad, any number is a scary number, even if it's tiny. But as far as just overall, we just haven't really seen enough people that are older that have it. As far as we know, there could be people out there who are 85 years old and have DUP15 and just were never diagnosed. So the fact that we don't know is, the bad news is it might be a shortened lifespan, but we don't know. The good news is it could very well be a totally normal lifespan. And, I think kind of both options are still on the table. I like to think of things a little more optimistically. So there's nothing right now that we know that's telling us that the lifespan is shortened. That might change as we learn more, but as of now, there's no reason to think it's going to be less than anyone else. Minus the SUDEP piece for a small number of people.
In general, I just want to add in this, anytime we've been asked, Oren has given this talk too, that people with DUP15Q in general with developmental disabilities, their lifespan tends to be a little bit shorter, but due to accidents, water accidents, it's not necessarily related to the syndrome. It's more about the symptomologies and the dangers that kind of come along with having a person with neurodevelopmental disorders. And so he addressed that, I think it was 2 years ago, but that's kind of what comes along with it. It's not necessarily the syndrome that's determines the life expectancy, is the other things like that.
Yeah, and the other thing that's a really great point, the other thing that I didn't mention, mobility is a big thing. People that are still mobile and can walk around, they're more likely to live longer, just because if you get to the point where you're immobile, you're just more prone to infections, and kind of the less mobile you are, the higher risk you are of skin infections, pneumonias, and if you get enough, eventually they can be tough to fight off.
Well, a big thank you to Ron for getting back on with us tonight. And we will see you soon. We wish you were here. We'll hopefully see you next time.
Glad I could see you guys again. All right. Thanks so much. Bye.